for Prof. Dr. Hendro, Dr. Bella, and online participant from some university and postgraduate student, and maybe in hospital. Yeah. Okay. Today. We are going to discuss about disaster health management in Indonesia. Maybe we can, we just not limited for budgeting, for many, maybe for other topic, maybe for curriculum and preparedness management in disaster. Okay. First of all, I'm Madalina Aryani, one of a researcher from Disaster Health Management Division, Center for Health Policy and Management, Faculty of Medicine, Universitas Gadjah Mada. And hello, Pak Budi. Pak Budi, your PhD student
Hello.
in Idol University. Yeah. Pak Budi, how are you today?
Oh, I'm fine. Sadika Fajan Salkan.
Okay. Yeah. Maybe Pak Budi will give us comment for health financing for disaster rating, and Pak Uji Kurniawan greeting for Professor Sao, because Pak Uji have to presentation today in Bogor, so they can't he can't join presentation today. Okay. Maybe and how are you, Prof. Laksono? Because last week is your busy week. You have to organize National Forum Health Policy Indonesia, and for you, yesterday you presentation in Poltekkes Yogyakarta. Yeah. Yeah, international conference.
And then back to the campus in the afternoon for another lecture.
Okay. Oh yeah. Every use a microphone. Yeah. Okay. Maybe to opening or trigger our discussion, I will representative disaster team to present about our activities in Indonesia. Maybe slide, please. Okay. Next. Okay, activities and related studies. In the nation, we know country of disaster laboratory. This is a map of multi-hazard risk map from Book of Disaster Risk Index in Indonesia by National Disaster Management Agency. But we can see it's a natural hazard, excluding man-made hazard, especially related to disease or health. So this is we think this is a homework for Ministry of Health and District Health Office to provide information about disease and outbreak mapping in Indonesia, I think, and coordinate with other natural hazard disaster in Indonesia. This is the conclusion of our activities, especially Gadjah Mada University activities. For the first time, type of our support for medical support, and we send team for response phase. Example event is Tsunami Aceh 2004. And after that, we think medical support is not enough. So we need more than medical support. And then for the next event, we send a medical and management support. We develop type of our support, not for medical, but for management support too. And we send team from response to recovery phase. This is an example event. And the last event at 2018, tsunami liquefaction in Central Sulawesi and tsunami Lampung. And then our program began to develop assistance for affected district, like make a health response map, disaster form, and health information, like a surveillance disease during disaster situation. Then we think we have to develop disaster health training and disaster health management curriculum, and we running from pre-disaster, response, and recovery phase. So we commitment to involve in any disaster management cycle. And this is our product for training and curriculum, disaster health curriculum for medical student, disaster nursing student, and health nutrition. And then in 2016, we began to develop disaster for community and family through program of community and family health care with interprofessional education. So we use disaster cases to our student understand about interprofessional education and for postgraduate program too in public health program study. And this is our related studies. In 10 years, we conducted any studies about we measure about level of disaster preparedness in district and province in Indonesia, and about a local budget and curriculum also. For the first type, related studies of level of disaster preparedness. The new one is when disaster strike. This is talk about disaster management, disaster health management progress in Indonesia and published in Indonesia Melbourne website. And then health sector preparedness during Idul Fitri homecoming across Indonesia. It's about road safety, but we talk about not about road safety, but about a local preparedness for to cope disaster event, and then earthquake, tsunami, liquefaction. How well our disaster health progress management in Indonesia, and we develop form and for health cluster when disaster and disaster preparedness level in health sector case study in Ende district for in 2015. And maybe this just conclusion. We always talk to a student, and we use this WHO health system building block system to understand about disaster. When disaster strike, disaster health management aims to keep the health system running normally despite in disaster or health crisis situation. For there is no different from normal situation and disaster situation. We have to keep health service, health workforce information, and other and financing is running well like as normally situation. Then the conclusion of our research, the finding indicate the moderate level B to C or is still low level of preparedness district in Indonesia, especially for health sector. It means health sector has been ready to cope with health problems during emergency, but we doubt it still have potential to fail in responding to disaster situation. And then one of the cause of an adequate risk preparedness is absence of contingency plan and limited budgeting for health sectors. It's related to our research. And then related studies for financing disaster. We conducted studies about budget of local government for disaster and health crisis Indonesia, budgeting for preparedness, case study on disaster simulation, and this is a great publication about health security financing assessment in subnational in Indonesia last year. The conclusion is there was a limited budget for disaster health by district health office. Because anything term about disaster is allocated by local disaster management agency, not in district health office or Ministry of Health. And then disaster and district health office just budgeting for disease outbreak for prevent and respond program. And This is the attribution percentage of study sample related 9 area joint external evaluation for function of international health regulation in 4 districts in Indonesia in 2018. First, after attribution analysis, we found that prevent and response function are still the main priority, the biggest budget for all regions. But the basis to make a budget, the regional capability to budget plan was based only on routine activities, not an event of previous year. They were not considering international health regulation, health security, and type of hajat for their budgeting. The picture is our discussion with health insurance agency, with local health insurance agency in Palu, and talk about claim of victims or patients due to disaster. So national health insurance doesn't accept any claim of patient due to disaster. Anything about directly related disaster event, national health insurance doesn't accept it. So this is our program. This is our problem. How we can treatment our victim after surgery, because they need to injury care, wound care, drugs, or maybe they need a walking aid. Who will cover the cost? This is our question. Maybe Prof. Laksana or Prof. Saul can comment about that. And we try to make a review of health security concept, international health regulation concept, and then health crisis and disaster law management in Indonesia. This is the theory of disaster from threats to recovery. So the conclusion is no threats. Not all threats can be disaster. We have the true structural damage and functional damage collapse, and then disaster declare. And this is the line. The second line is disaster cycle. Disaster cycle by Indonesian law number 24, pre-disaster, disaster, and recovery. There is no structural damage process and functional damage or public emergency cycle. And this is the third line is 19 technical areas of health security, international health regulation, from prevent, detect, respond, and other international health regulation and point of entry. 19 technical areas, there is no gap about theory of disaster cycle by Indonesian law, and 19 technical areas. But when outbreak or this is gap of determination of status, level status. This is a response. Emergency or not? Because when outbreak happen, the status of outbreak is declared by District Health Office or Ministry of Health. Outbreak doesn't mean disaster by local disaster management agency or local government. And unexpected fund budgeting by local government through local disaster management agency is used during response phase, not for outbreak phase. So need a formal statement for disaster status by government or region. This is the gap in our country. And next, this is a related studies about disaster health curriculum for students. We evaluate our programs on emergency and disaster course funding to community and family healthcare, and then research based to maximize effectiveness of simulation for hospital disaster training. And we produced policy brief challenges for curriculum development in disaster health management, what we can do in Indonesia. This is the framework. We try to we have to coordinate about disaster cycle and education cycle. So when disaster happen, increase need for health services. So in in higher education, we have to fulfillment of healthcare workers for provide health services, and this is we use a competency-based learning. But the problem is experience-based learning. I think it's not from in Indonesia. I think in other countries, everything about disaster curriculum based on experience-based, not a competency-based learning. So we have to standardize curriculum for disaster health management. And then for compulsory or elective course, many course about disaster is elective course, not a compulsory. Okay, this is the famous fourth word. The most problem in disaster response was not lack of any single resources, but control and coordination by World Association of Disaster and Emergency Medicine. So we try to develop interprofessional education by cross-cutting competencies for healthcare workers from SU publication. Okay, maybe there is three issues for discussion today: how to make a good disaster health planning, how to budgeting for disaster health, and how to make standardized disaster health curriculum for health students or our health workers. That's it. Maybe Dr. Bella, Dr. Handoyo, additional comment, or Dr. Hendo. Yeah. Okay, we can start discussion today. Prof. Laksono, Prof. Su, yeah, or Pak Budi, or online participant. Yeah, Pak.
Please start with the first slide.
First slide. First slide, please.
First slide. No, no. Terus.
Next.
Nah, terus sampai terakhir.
Pulpen.
Yeah. This is process
Pak, pakai mic.
This is the process of how we develop this working group. Yeah, you can see that the special thing in this development, because we develop this group not by learn or study abroad or to other institution, but what did we do is learning by doing. Yeah, because we have limited resources, limited institution to study what is the disaster. And in fact, we have more experience with the disaster. So we start to join the WADEM was in 2007. It means 3 years after tsunami, after we start with our activity. Yeah. WADEM is the first institution which we learn about the disaster. Yeah. And now we still connect with the WADEM, and then you can see that in the first time our response is instinctive response. It's instinctive response, and by chance, Prof. Laksono, after tsunami in Aceh, Prof. Laksono go to Banda Aceh, and I go to Melapo. It's different place, and we perform different support. Prof. Laksono with management support, and I go to Melapo with medical support. We don't make a discussion before. It's just instinctive. Yeah, you can see this is what interesting with our group, and we're lucky because we have now we can get the staff, smart staff like Dr. Martilina, Dr. Bella, Dr. Handoyo, and so on. Yeah, that's my comment.
Yes, yes, I think what Martel presented is very interesting. We have a long history of sending medical team, yes, led by Pak Indro, and management team. Yeah, it was led by me, but now it's led by Pupila, and now the medical team also replaced by Pak Handoyo. Yeah, yeah, we have two generations now. Now we are the old generation, and they are the young generations. Yeah, and yeah, yeah, yeah. We have a regeneration when I think 6-7 years ago. Yeah, we had the change of generations. Yeah, we have been in this activities since 2014. No, 2004.
Yeah, that's
So
not
15 years ago.
Yeah.
1-5. Yeah. So we work together. Yeah. And like Manuel mentioned about the funding. Actually, when we look at the funding, is mostly it was funded by philanthropy. Yeah. Like the medical team led by Pak Hendro, it was supported by some donors, yeah, Pak, in the beginning. Also, some personal expenses support is a small amount of money, yeah. But also in the Aceh tsunami, we had very big funding from World Vision for the next 4 years. So only 3 months for the small funding from local philanthropy here, and then about 4 years from the big philanthropy from Australia, World Vision Australia. It is very little from local government because they don't have enough money for this. So actually, when we look at in the future, after 15 years, the challenge is not only relying on government money, but also from humanitarian, from philanthropy resources. And 2 months ago, we tried to start for like funding collection before the disaster, because usually we collected the money or the funds after disaster. Okay, so the challenge is how to have like a preparedness fund. Yeah.
Yeah.
So we have to prepare before the disaster struck. And this is very, very challenging because actually when we look at our experience after disaster, there will be a lot of funding. But for the first 1 to 3 days, the most critical time, usually lacking of funding. Yeah. Are you following my points? That after a week after the disaster, then there will be like, yeah, maybe piles so many or so much fund come from many resources, but the preparedness fund is not available.
Yeah.
Yeah. Okay. So we try, and our experience of for one night concert, small concert,
Yeah.
it can 30 million. Yeah.
Yeah.
30 million rupiah. 32 million. It's good start. Yeah. So I think we have to do more campaigns for this. Okay.
Okay.
Yeah.
Okay. Next comment from Prof. Su. Maybe you can talk about how to how to use system thinking for to increase level of preparedness. Maybe. Okay.
Actually understand correctly. And that diagram that Professor
Oh yeah.
mentioned. Okay, so basically this is the framework from the group,
Yeah.
the management, right?
Yeah.
In terms of different phases, and there is another diagram which you have on the left hand side, the disaster management, and the right hand side, the education. Can we go to that one, please?
Yang mana? Yang mana?
This one. So here, when is this theoretical or is this something that is the framework for actual policy?
Yeah.
Like for example, we have preparedness here, we have planning here, and when disaster hits, then where is the flow of money coming in here? Meaning we have preparedness and preparedness in terms of having the health service facilities ready, personnel ready, or is it including funding?
Oh yeah. Yeah, doctor. Mike, please.
Maybe I can give answer for a part, not totally. For example, the preparedness. It is our work. It's not only theoretical framework. It's our framework. And for example, preparedness, we develop preparedness in the form of hospital disaster plan.
Yeah.
We
Services provided at that time, the immediate response.
yeah, immediately. So after pendampingan apa? We give assistance to the hospital to develop a hospital disaster plan. And apa namanya? About the finance, yeah, you can ask Dr. Prof. Laksono or Madel. But it's true that we give support for disaster in the way what we can do, and in this and for example is in the form of hospital disaster plan, and the financing Madel will tell you.
Yeah.
Yeah.
How does the government money flow?
Yeah. Okay. For preparedness measure, we have to strong commitment to accompaniment Ministry of Health and district health office or provincial district health office, and then district health office has to socialize to healthcare facilities for primary healthcare and for hospital.
So that's extra budget.
Yeah. So
going from the government.
Actually, they have to prepare for budget.
Right.
For the but in the reality, hospital has to independent budget to make an independent budget for hospital disaster plan.
To request.
Yeah.
To request.
Sometimes hospital request to local government
after the disaster.
After disaster. Yeah.
Okay.
After disaster.
So that's I like the idea. Let me follow the idea that Laksono mentioned earlier. Actually, in your topic here is the financing of the disaster management, and the focus is basically after the disaster.
Yeah.
Okay. So I think the word preparedness means something that different groups or different agencies, different people might see the word preparedness differently. And preparedness not only include the facilities, the personnel, the supplies, and this, that, it includes the money.
Yeah.
So if government of Indonesia or government of any country in the world, normally they have certain unspecified budget on reserve. And I think probably there need to be some money already on reserve for disaster preparedness.
Yeah.
As a kind of fund like this. I'm not sure whether Indonesia has this one. A fund for disaster preparedness set aside to be given immediately, because it's similar to epidemic and many things.
Yeah.
We know it will happen. We know it's for certain in terms of probability. Probability is 1, meaning 100% it will happen. But what we do not know for certain is when, what, and where, and how much, meaning how severe. So these are what we don't know. It's similar. Actually, I think it's similar to health insurance. Health insurance, individually, we do not know whether which individual will get ill and with what disease and how severe. But when we pool the risk, together, we can tell the probability of that risk. Same thing for disaster. We can tell on the aggregate collective level the risk of this disaster. And for Indonesia, for each year, the risk is certain, meaning 1. The probability for any disaster to hit in Indonesia is 1. It will be certain. Okay.
Yeah.
So I think same thing for insurance, that we pool the money into the insurance fund because we know in a year someone will get sick, and we can calculate the probability of illness. We can calculate the average number of visits, right? So it's more difficult to calculate the number of visits in terms of it's easy for regular for kind of regular diseases, but for epidemic it's very difficult to calculate, and we can consider disaster as epidemic.
Yeah.
Right. Same thinking. So in this sense, there must be a fund, a pool fund for disaster preparedness. And it should not, government or any organization should not wait until the disaster hits and then the hospital or whatever health facility and health personnel in the front line to see that we need this, need that, and we request. Because by doing this, it slows down the process, because requesting budget, requesting supplies takes time. And during emergency, we must not waste any time. Even 1 hour, 1 minute, we must not wait. So there need to be this. And the money, it should be given in terms of supply instead of money. Because during the disaster location, supply is always shortage. And if you give them money, they will have to get some personnel to buy. And buying locally is more. So there needs to be something identified in the list of supply. Say if this is earthquake, what kind of supplies needed? This is volcano eruption, this is tsunami, this is whatever. What kind of supplies will be needed? So simulation, no need for I'm for system analysis, and I do computer simulation, not kind of work. But sometimes it's just brainstorming. We can simulate the needs, right?
Yeah.
So the disaster, the preparedness money, that should be it should be there, and the supplies and personnel should be already arranged, already organized, ready to move within one protocol. And then say, I think that's my thinking about preparedness. And no need for people who work very hard and a lot of overwhelming in the field to think about where to buy something. The something needs to be sent like as something, not as money. So that's thing that I think we need to have a regular preparedness fund. And regular preparedness fund, we need to have it. The main responsibility should be the government responsibility. And I think for non-government effort, it can also be done. And I like Dr. about the private sector can organize something. And actually, it doesn't need to be limited to, it can be international. Because when anything problem happens, there are many organizations in different countries go right away. Right away, it exports with money, with supplies, with so many things. And if the coordination of this is done before and because preparedness is not just one word or one box.
Yeah.
It has to be something that can be, we press a switch or click, it should come right away. So that's my thinking.
Yeah. Very good.
Our assistance is after the disaster. For example, for volcano eruption, we give before we do assistance before the last eruption, but after the previous. You can get, yeah, because we have experience in volcano eruption in 1994, the big eruption, and secondly in 2010. So the preparedness in 2010 is much better because it's performed before the disaster, but after the previous disaster. Yeah, okay. And secondly, may I give you information that our government have is already have it's funding for disaster, but the bureaucratic rules make it difficult. Jadi kita kan sudah punya dana di BNPB. Yeah.
From National Disaster Management Agency.
Yeah, we have a national agency of disaster management, and they have enough fund. But how to get the fund is the other problem. Yeah, that's it. Yeah.
We think we need to develop or not develop like actually we have a funding from the National Disaster Management Agency, but for the health this is so limited budgeting. This is a problem with us.
Because we talk about disaster health management, not disaster management generally. Yeah. Yeah. Yeah.
Specifically allocated to health.
Yeah. So we got the challenge for budgeting is to full fund for preparedness, especially when we talk about health security. We talk about not for outbreaks. We advocate to World Bank when we talk about health security. It's not about outbreaks. It's about disaster and other hazards, social, road safety, anything. Not just about outbreaks. So we push them to understand about framework, about this framework. This is a law of Indonesian law of disaster, and this is 19 technical areas of health security. So, but this is the gap, like you mentioned before. District Health Office is a separate institution with local disaster management agency. Ministry of Health is separate ministry for National Disaster Management Agency. So an unexpected fund from national or local agency for disaster management, it's it used during response phase when the national government or district government declare this is the response status, this is emergency status for our area. So it's so really cases that the outbreak is declared as disaster. So for health sector, we also have limited budget. Actually, anything about disaster also impact to health sector. Earthquake, desert, so impact to our sector, the health sector. So we advocate district health office to advocate local disaster agency, and we advocate they are across sector must collaborate and coordination each other for fund of preparedness. So local agency for disaster management, not to think about natural disaster, any other disaster like a disease, outbreak, road safety, social conflict. So you have to think about that, not just about natural hazard. Yeah. I got your idea. Yeah.
Thank you very much. I have very little knowledge about what happened in the system in Indonesia. So it's an opportunity for me to learn.
Yeah.
I think one thing that
please.
yesterday I talk about the system thinking, and I think we should look at disaster something before, long before, and long after the disaster. I showed picture of some disasters that happened. This is I never had any education about disaster, but I use system. I am from the system dynamics. Actually, my background is pharmacy and public policy.
Yeah.
But I use the system thinking and look at some historical events. And in Japan, when the east coast of Japan, it is in my slide and it's down. The notebook is downstairs. Sorry.
Okay.
It's in 3 months. In March, disaster hit, triple disaster, earthquake, tsunami, and then the nuclear power plant.
Oh yeah. Okay.
And after 3 months, they remove all the debris, all the garbage, all the whatever that caused by the disaster. And that is the beginning of rebuild, reconstruction. But in Haiti, 2 years later, you will see people still living in tents. And my assistant was very good. I instructed her to find out the picture of the same place. And it's very clear that in Haiti, in the same place in Japan, everything was clear after 3 months. The same place in Haiti, when immediately after the disaster, the things coming down. And 2 years later, they just clear the things like this and had small road, so people can commute. Now, if we do research, physical health and mental health, what happened for people who live in that place in a tent for already 2 years after the disaster? And what happened for people to have to commute every day through the both sides, something falling down since 2 years ago? So I think health professional can, after if we do more than just service provision and do research, and we'll show them and they will listen to us. But it takes time. It takes a lot of time. So if we can do this, then I think they will know that health implications happen in all the whatever happened in the disaster. So budget for health also relate to budget for removal of the debris. For in Sichuan, China, after 2 years
Interesting experience, Prof. So, and I want to ask Budi or Pak Pauji, any comments or idea what next we must do, or
Oh,
other
yeah.
participant, online participant? Ya, kita pakai bahasa Indonesia juga nggak apa-apa. Pak Budi?
Oh, yeah. Hello, Madel.
Oke.
Yeah.
Ya, please.
Thank you for your time. Actually, it's very important because right now, let's say, if we talk about disease screening, disease screening right now, at the first, we think that it have to be covered by health insurance, right? And right now, it's moved because they concerned about double costing. They don't want to, or if the health insurance agency already budgeted, so it's no need to budget with the local government. So since 2019, this is screening allocation is moved from BPJS or our national health program to local government. So if it's very interesting for the idea to apply in health disaster management about the pooling, because I think maybe we still not do the same way. I mean, or try to pooling it, try to calculate what the probability and how much the cost, something like that. I think we still not do it until now. And if it's happened, it will be great, especially if we try to involve with another stakeholder too, not only in health sector. But for this first one, maybe we can start in health sector and related health sector. And my question is how the trick, I mean, how the tips to do the advocation. Oh, yeah, we already know that this disaster management give impact not only in health, but also in another sector. But how to advocate that, oh, yeah, so that's mean we need pooling thinking. I mean, that pooling thinking to arrange and planning that budgeting, not only to say that, oh, we need that budget, but actually we don't need that much in every sector, maybe just a little, but please contribute. Or we also will thinking about how to the method for revenue collection. I mean, maybe it's not only from the government, but also we try to collect this to another source. So we think about the revenue collection. Is the we want to know more. Maybe have experience from another country about the pooling and revenue collection for disaster management. Yeah, thank you.
Yeah, okay. Good question, Pak Budi. The answer is decrease ego sector. How to pulling preparedness, how to pulling fund for preparedness is decrease ego sector. I don't know. I'm just joking. Maybe Prof. Laksana or Prof. Sao or Dr. Hendro. Oh ya, bagaimana mengadvokasi agar ide pooling tadi itu bisa kita gunakan pada situasi bencana, pada saat kesiapsiagaan. Back to the quote. Okay.
Because we already have fund.
Please make
But how to coordinate to get the fund from the source?
This is
Yeah.
important.
Yeah. It's our quote is like that.
I don't think that it is possible to. I don't think it is possible to collect fund from premium or taxes the same way as we do it for health insurance, because it is a random event. Although aggregately, collectively, we can tell the probability, okay, with the data. But in terms of political feasibility of using a government mandatory mechanism to collect from individual, I think politically the feasibility is low. But the government always allocates certain fund in the like central fund to do things that probably not really specified on a particular thing, and that need to be allocated to disaster fund. And in disasters, I believe that it is possible to also draw from private sector and also the philanthropic sector. That is, I think, is possible. So although the probability of happening, the risk, when we calculate the risk, we can think by comparing to health insurance. But in terms of inflow of fund to this particular pool, I think it's very difficult to get individual to have mandatory individual contribution the same way as premium. It needs a different set of mechanisms. This is my personal view.
Ya, mungkin saya nambahin komentar ya. Jadi, you are right that funding from private sector is possible because we have many big company and they have CSR, corporate social responsibility. As there are many funds there, and then in Indonesia there are many NGOs, private NGOs who have more funding, a lot of funding. So the problem is how to coordinate them.
Exactly.
Yeah, how to coordinate them. That's and a national system, a national insurance, BPJS. They also have money to give fund for the victims, health insurance, national health insurance. But again, the problem is the bureaucratic rules. Nanti tolong diterjemahkan, Pak. Jadi kabar terakhir itu di Ambon, itu rumah sakit menstop pelayanannya, pasien disuruh bayar, yang nyuruh BPJS karena sudah lewat masa daruratnya. Padahal tanggal daruratnya belum lama di Ambon.
Yeah, please.
Yes, and there are some bureaucratic problems. For example, although the program is not yet terminated, but the budget already finished, unrelated. Yeah. So, yeah, I think that's why when we look at the funding resources, the bureaucratic funds or the government fund usually is very bureaucratic. It's difficult. Yeah. That's why I think we have to complement with the financial resources from private, and that should be like a good balance. Yeah. In our experience, we don't use a lot of government funding because they have so many regulations. But also we work together with government. But most of our budget, if we look at, also come from private. Okay. The point, yeah, ini I will talk in both bahasa and English. Yeah. In English, the point when we have to collect the fund in pre-disaster. Yeah. Jadi tantangannya bagaimana kita mengkolek pre-disaster. I think it is impossible to use government funding for this. Ya. Tidak mudah, tidak mungkin mungkin ya untuk mengambil dana pemerintah. So I think we have to make like campaigns for collecting the fund, maybe using like the terms like the Friends of Gajah Mada for disaster, something like that. Ya. Jadi kita perlu kampanye untuk mengumpulkan teman-teman yang sukarelawan donasi yang mau membayar, misalnya kita mengumpulkan tahulah 100 nama, 100 names ya. So we can collect 100 names of maybe philanthropists that maybe in each year they pay 1 or 2 million rupiah. So at least we have about 200 million a year. Yeah. So this amount can be used for like the first response to the disaster area without looking for post-disaster money. Yeah, are you following my point? Yeah. Jadi this can be used for like a bridging. Yeah, so we can send to the disaster area at least for 1 week needs. Yeah, because our money dispersed or other money will be collected from other fundings. Yeah. So this is the point. So I think we have to make this becoming like a culture in our groups. Jadi kita akan membuat daftar nama, gitu ya, daftar nama orang-orang yang memang mereka tuh mau menyumbang, ya. Mungkin juga perusahaan juga bisa terjadi seperti CSR, dan ada atau tidak ada itu mereka juga mau menyumbang. Misalnya 1 tahun 1 juta rupiah nggak mahal, loh. Bisa ada 100 nama. Bisa nggak ada 100 nama, Bu? Kira-kira 100 tempat. Nah ini. Ya. Kita harus kolek semua nama-nama tadi, dan kita sodori aplikasi gitu ya. Masuk aplikasi juga kita akan nyumbang untuk kita sendiri ya. Seperti saya juga akan nyumbang, saya Pak Edo juga akan nyumbang juga, saya atau ya. Artinya memang kita we try to develop a fund for preparedness. That is something we can do like that. So as I said that in one concert we can collect 32 million, yeah, only one night. Yeah, so if we can have a 1 year campaigns, yeah, then we can have maybe 100 or 200 million, maybe. Okay.
Maybe I'm not sure whether it's a good idea or not. I would like to add to this that this fund, when it is collected, maybe there need to be management about investment and allow liquid fund to be used immediately. And another thing is that is there a possibility, maybe the structure, the governance of it, to allow the interest, to allow for the money invested and the interest coming from that to be used to organize training for disaster management, which the university can play a big role. And with regular training, and it can be news all the time. So maybe this year we all news, and so every training people will know, and that will be more opportunity to draw in some more inflow of money to the fund. And at the same time, the training also help people and make people aware, and then get better preparedness for doing the next round of disaster management. So that's a little bit proposal.
Yeah. I think for training, we can use the training budget if we can propose. Yeah. So I think this is again back to the issue of how the government think that preparedness is good. I think training will be there. Yeah. But the problem is there is a disaster that we don't know when it will come. Yeah. Then we don't have enough resources to send the team there. This is the point. Yeah. Training, I think we can influence people or the government. They can provide the training budget for this. Yeah.
But this can be an advertisement for the fund.
Yeah, but the fund should be from the government training, not from. Yeah. or maybe from the hospitals, public or private hospital. They have the budget for training. They have, yeah. But the critical things is when we have to go to the disaster, like when we went to Aceh, Indro, I think you get some money from, I don't know, yeah, personal network, yeah, institution, yeah, yeah, out of pocket, also like collecting many small money, yeah, so yeah, so this kind of thing that we can prepare, yeah. But for training, we can propose to the government budget, no problem. Okay, so you know the point that the contingency fund, that is very important, yeah. That maybe the fund will not be used if there is no disaster. Yeah, that is the point. Yeah.
Advertisement for
Yeah.
the fund so that more people will donate.
Yeah. Okay. Okay. Is there any question from online participant? Ada pertanyaan dari webinar? Mas Oji? Pak Pauji?
Halo,
Ya, halo?
halo Mbak Madel.
Ya.
I'm sorry I can attend in the forum. No, I'm in Bogor. I think it's very interesting for the Madel presentation. This is about the local budget for disaster. In the security, we know if any four function in the health security. One for response, one for preparedness, hazard, and to detection. And I think for budget, local budget, the local government not ready for the to function as preparedness and detection. So this is related with the Budi mentioned about the disease screening, and we and in this morning I have information about the new regulation in BPJS number 7 for 2019 about the capitation based on performance, not only based on commitment, but the changing about performance. For the related is disease screening. It's the product of promotion from the primary care. So I think the team disaster for the budget more advocacy due to local government about preparedness and detection. So and the national health insurance not covering a patient from the disaster after hits or injury. So that is clear regulation from the MOH and BPJS health agency. So I think this is important things for the budget allocation. If we have primary flow of framework for the detection and preparedness. Thank you, Mbak Made.
Yeah. Thank you, Pak Pauji. And maybe I have a question for Pak Pauji, Pak Budi, or Pak Laksono about this problem. Is there any scheme of fund from National Health Insurance to cover after surgery, like a wound care, morning aid, what have to get a wound care, but national health insurance doesn't cover the claim. So
yeah, I think we know that the government they don't have enough money and the BPJS. That's the fact. Yeah, yeah, jelas sekali. Yeah.
okay, Pak Fauji, Pak Budi, 20 minutes left. Maybe Pak Budi, you are you are the person of initial discussion today. Do you have any idea for the next we must to do? Maybe to develop community of practice, special for financing for disaster health, or anything
Yeah,
else?
yeah. Thank you, Madel. Actually,
Or exchange program?
oh, yeah, it will be interesting, Madel, because at the before, community of practice and in health financing and health insurance and community of practice in disaster health management uh, have a different activity, but right now, today we try to initiate it together. So in the future, we try. It's not only for first time and the last time. We will try to conduct this activity again, and we try to um, make cluster in an health financing team who interest deeply for health disaster management, and then also both side in health disaster management who interest in health financing. So after that, we have a small community of practice to follow up this activity again in the future. And yeah, we will find not only for um, possibility of research or possibility of training idea, but also maybe in this way our community of practice also can um, facilitate us and introduce us to private sector on philanthropy who can help us, right?
Any
Yeah.
comment, Prof?
Ya, Pak Budi, bisa nggak untuk melihat di Thailand bagaimana Pak tentang filantrop ini? Kamu pakai kamera. Ya. Oke, untuk melihat filantropi di Thailand, ya, Mas Budi ya. Kalau di
Terkait
sana,
pidana kesehatan, Prof.
ya untuk kesehatan ya, mungkin
Oh,
jawabannya
baik,
gimana ya.
Prof.
I asked about how the philanthropy in Thailand because you have the king and the king is very well known for donating money for hospital like Sirirat's Hospital, yes, and the big one, private wings of Sirirat's also, yeah. So can you explain to us, or maybe you have some energy to write about philanthropy in Thailand? Yes,
Oh,
silakan.
yeah, Prof. Laksono. Actually, for philanthropy in Thailand, I don't know too much, especially for the king budget, but maybe Ajahn Sawakon can explain. But as long as I know, um, many many support, not only for policy but also for budget is um, structured by our king. As let's say, for example, when we conduct benchmarking in a hospital, the hospital not only provide alumni or family in the hospital who try to collect not only from industrial but also from another philanthropy, but they also try to propose or get some, not propose, a little bit like similar with get some support funding from the king for patients who cannot support safety costs. But for the detail, maybe I can Sawakan, because I'm a little bit worried if talking about commitment from King for budget allocation. Thank you.
In Thailand, the royal family, the king, the princess, and many members of the royal family do a lot of kind of assistance to the population. And Sri Raj Hospital was given a big amount of money by the present king. Aside from in addition to the royal family activities, because royal family has a lot of foundations and they do it regularly. For disaster management, what we have found, Thailand is fortunate enough to have not too many disasters in terms of natural disaster. We have something that on Saturday I call part of the disaster might be man-made. Like for example, we cut a lot of forest, and then every year we have drought and we have flood, alternate. Before it's alternate. This year drought and the next year flood and drought and flood. But this year, 2019, at the beginning of the year is drought, and then 4 months later flood. Okay, and maybe in a few more months drought again. So I call this man-made part of disaster. Okay, in Thailand, when there is disasters, people, the king, the royal family, and the companies, the people, individuals, they all very quickly they pour the money in. Okay, but that when the disaster hits, we do not have a kind of specific fund that we hope to have preparedness for disaster. The preparedness is not in terms of planning or anything, but people are ready. Altruism is quite good. People go right away and then immediately, and even they fly to the disaster area, they travel to the disaster area and see what they can do, and they just do it. So that's the thing that we feel so happy about. Anyway, we are talking about Thailand, which doesn't have much, I mean, in terms of the events, disaster incidences as Indonesia. And theoretically, if I remember correctly, WAC staff talked about if you do something, it can be based on to equalize it, to equalize the society. You can base on altruism. But then altruism is something that is irregular, it's random. So even with altruism, we need to systematize it. So it would be good for altruism to use altruism to pool money and manage it systematically. And in Thailand, we still lack that. Even the 13 kids who were trapped in the cave in Chiang Rai not too long ago, a lot of domestic and international help went in. So that's the kind of thing that we can expect. But we do not expand that thinking to trying to prevent what is preventable. A lot of times disasters cannot be prevented, but there are many times disaster can be prevented with good management, and we still lack that part. So in conclusion, Thailand has a lot of altruism, but we need more. We need more systematic management of disaster. Thank you.
Okay. Maybe the last question. 10 minutes left. Oke, silahkan Pak Nyoman. Pak Nyoman, silahkan dibuka. Halo?
Oh, yeah,
Oke,
yeah.
silakan.
Okay, yeah. I'm Nyoman Kumara, MOH and WHO retiree. Currently, I assist MOH in developing the so-called National Action Plan on Health Security. So soon it will be launched, I think by the end of this month, something like that. But I would like to inform that actually uh, uh, outbreak, epidemic, etc., is categorized under the non-natural disaster. Yeah. So actually we have natural disaster and non-natural disaster. Yeah. This is where the health outbreak or epidemics belong to. Yeah. So in this national action program, actually the primary intent is to implement IHR 2005, in the prevention of pandemic due to biological and then chemical and radionuclear agent. Yeah. So it has been widened, yeah, from the previous IHR. Yeah. For this, we categorize the 19 technical areas into prevention and then detection and response. So those 19 technical areas covers all public health emergency of international concern caused by biological and then chemical and radionuclear agent. Although currently, I think we know that pandemics are mainly due to infectious diseases. Yeah, avian influenza, SARS, MERS, and the most recent one, Ebola. Yeah. So that's why we work cross-sectorally in preparing this NAP or National Action Program. Yeah. There we calculate the cost, yeah, for each technical area. Yeah. Well, of course, we are also collaborating with GHSA, a forum, created in 2014 by the US. GHSA stands for Global Health Security Agenda. So GHSA assists WHO, yeah, in implementing betterly IHR 2005. Yeah. And about the budget, of course, we can ask, from the BNPD, yeah. BNPD is the local disaster management agencies. And it is also worth mentioning that in the SPM, yeah, standard pelayanan minimal, yeah, one SPM at the provincial level is dealing with emergencies. Yeah. So SPM is actually 12 activities that are mandatory to be implemented by the local government at the district and at the municipality level. So SPM is actually a high priority. Yeah, that's why we have allocated also budget, I think, for the provincial level. So I hope this will clarify some item discussed in this forum. Thank you very much.
Yeah. Thank you, Pak Nyoman. Pak Nyoman mentioned that there is one new regulation, national regulation about the standardized healthcare minimum standard for healthcare services. for provincial is to cope vulnerable groups and victims from disaster. Yeah, we can push or advocate district or provincial to cover any budget by this regulation. Okay, thank you. This is the final. This is the final session for today, but this is not last discussion, because initial discussion for the next step. Please, the all participant webinar and participant in this room, commitment to develop small community of practice about financing for disaster health management, I think. Oke, Pak Budi, siap ya yang buat Thailand? You are a PI from Thailand. Okay, thank you very much for everybody. I'm very grateful for Prof. Sao, Prof. Laksono, and Dr. Hendro, Dr. Bella. So see you next time. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang.